Good evening, good morning for those of us in the States, and good afternoon. Thank you everyone for joining us. I'm Megan Quitkin. I'm the Deputy Director for Policy in the union's Tobacco Control Department, which I joined a year ago. I'm going to go out on a limb and acknowledge that it would be nicer to be doing this in person in southern Spain, but we appreciate your being here and coming to us from a variety of time zones. Just a brief overview and order of events. I'm going to speak a bit about the union's work on smoking and COVID-19. I know that you all have our latest brief, as well as our master living document. So I'll touch on some of the main highlights from that. And then I will pass on to my colleagues who will speak in the following order. Dr. Prasad from WHO, he's the head of unit for the Tobacco Free Initiative. He'll be joining in a moment. Dr. Catherine Egbe, who is a special scientist at the South African Medical Research Council. And then finally, Dr. Tom Hurd, who is a research partner in Stopping Tobacco Organizations and Products. And we should be able to have a nice roundtable discussion for a good 20 to 25 minutes so people can ask questions, and I will moderate that. If you want to type questions into the chat, I will be happy to direct them toward my fellow panelists. So as you likely know, the union has been deeply concerned about COVID-19 since its emergence in December 2019 in Wuhan City. Our attention quickly focused on how this novel coronavirus, which primarily affects the respiratory system, might affect the world's 1.3 billion smokers, 80% of whom live in low and middle income countries, which are already plagued by tobacco-related diseases. Less than 2 months after the virus appeared, a seminal piece of research from China was published in the New England Journal of Medicine. It found that when compared to non-smokers, smokers were 2.4 times more likely to be admitted to an intensive care unit, need mechanical ventilation, or die. Several weeks later, and just one after the WHO declared COVID-19 a pandemic, a second study out of China found that while smokers accounted for just 8% of total cases in the sample size, they comprised 12% of severe cases. It was off to the races, so to speak. Quickly thereafter, there were a number of other critical publications. Tobacco-induced diseases similarly found a likely association between smoking and the negative progression of COVID-19. Early April, the US CDC found that people with underlying health conditions and risk factors, including smoking, might be at a higher risk for severe disease or death. A mid-April meta-analysis of 12 published papers found that smokers had 2.25 times the odds of severe COVID-19 outcomes than never smokers. At the same time, in early April, I would be remiss if I did not point out that some studies were showing quite the contrary. There was a very large study out of New York University, which located in the what soon became the epicenter of the epidemic, that did not find smoking status associated with increased risk of hospitalization or critical illness. And of course, there were the 3 now infamous studies out of France, which garnered significant media attention, confused many already anxious people, and even led to France limiting nicotine sales. These papers made bold claims. Smokers were less likely to get sick, smokers were less likely to be infected with SARS-CoV-2, and nicotine might have some protective factor that could control infection. So needless to say, the union's tobacco control department felt a strong need to weigh in and carefully analyze the literature that was being very quickly turned out, often in preprint without peer review. Our goal was and continues to be transparent and highlight important findings, raise awareness about study limitations, and synthesize hundreds of articles in a clear, compelling format that could be understood by public health and non-technical audiences. Since mid-May, 4 of us on the tobacco control team have reviewed the scientific literature to enumerate what's presently understood about the tobacco usage and the disease. We maintain a living master brief that I alluded to earlier. It has frequently asked questions, which we will update. And we also produce a now monthly brief on the latest science that's really most relevant. So just briefly, some of our major findings to date. We have reviewed hundreds upon hundreds of articles over the past 5 months. There are several takeaways that I think are really important. About 6 weeks into our process, we realized it was important to create a disease spectrum and review research as it pertains to each of sort of 3 buckets. So the first stage is infection with SARS-CoV-2. The second stage is emergence of symptoms that require an outpatient visit or hospitalization of 24 hours or more. And the third stage is when things get quite grave and result in need for mechanical ventilation or death. Regarding stage 1, there have actually only been 2 epidemiological studies focused on this, one from Israel, one from Kuwait, that have attempted to address infection risk among smokers. Both actually show evidence, early evidence, of reduced risk of infection among smokers. Regarding stage 2, there are several studies that look at the emergence of symptoms from the US, UK, Denmark, and Mexico using a large database provided by the MOH. Many of these have found that smokers were less at risk of entering disease stage 2. So what's going on here? It's certainly possible that a number of anything is certainly possible. We're still in early stages of the disease. But what we are finding in many studies does have surprising results, sort of contrary to what you would think. And I want to talk a little bit about this because there are problems that emerge over and over again. The first is regarding major misclassification of smokers. The large database in Mexico that I just alluded to did not account for former smokers who were likely recorded as non-smokers. There's major underreporting of smokers across studies. We saw this happening in many Chinese studies where smoking status is frequently, even not during the midst of a pandemic, not captured by healthcare providers. This is a pervasive issue in GATT surveys, for example. Frequent reliance on hospital records to determine smoking status. When hospitals are overwhelmed, for example, during a pandemic, they're not a great source or an accurate source for smoking status. Other important study limitations, which are summarized in our most recent brief and which we've seen over and over again, is potential for bias. Certain subgroups are at increased risk, healthcare workers. Presence of COVID-19 symptoms could have smokers seeking testing, which would increase sample size denominator. Testing. Smokers may have disrupted mucosal epithelium, which could alter assay sensitivity. Electronic health records. These are most widely used and they're horrible at capturing smoking status. Recent or just quitters. Patients may have just stopped smoking and are thus erroneously labeled. And poverty. Smoking is far and wide at a disease, a practice associated with impoverished subpopulations. Smokers may die at home rather than being tested at a healthcare facility. Disease stage 3. This is where the strongest evidence has emerged and continues to emerge over the past few months. Including a number of very strong meta-analyses, which have shown 7 months into the pandemic that smokers who reach an advanced disease progression requiring hospitalization are at greater risk for extreme outcome than not smokers. These studies are not perfect, but because there's such consistency across them, this is what we can say with the greatest certainty. I am now going to pause or stop my presentation so I can invite Dr. Prasad to speak. I believe he's here with us now from WHO.
Thank you, and good afternoon, and good morning, good evening, colleagues from different parts of the world. Couple of thoughts before we get into this limited discussion. One is that tobacco kills 8 million people every year. There's no doubt about that. And there are 1.3 billion tobacco users in the world. More than half of them actually want to quit based on different surveys. So they are all addicted, they want to quit. So that this are 2 important facts. And the third important fact is that tobacco leads to non-communicable diseases, premature deaths due to NCDs. And we can list them out: cardiovascular diseases, chronic lung diseases, as they call it, COPD. Even is a comorbid condition for diabetes, for example. Cancer, of course, everybody knows. people know that now the risk of dying from TB is 1.5 or 1.6 times more if the smokers continue to smoke. So what we have seen in the narrative in the last 5-6 months since COVID is that the tobacco industry has tried really hard. And some researchers, of course, who would want to see, looked into numbers alluding to nicotine being protective. There are less number of smokers getting COVID. And as very well pointed out by Megan, these are fraught with a lot of risks. So what's established is established. Tobacco is a risk factor for NCDs. And what's established now from a number of studies in the last 4 or 5 months is totally established is that the severity of COVID infection is higher. The severity is higher. It's logical because the smokers are having other comorbid issues. Then they are also prone to getting into hospital and getting into severe infection. But the point sometimes made is when you start looking at numbers and hard numbers. Again, countries are trying to save lives. And at this point of time, when they're trying to save lives, who's taking, especially in developing world countries, smoking status? And so, I mean, as a physician, I would say, oh, in a hospital, I'm checking on the patient to save him. He said, are you a smoker? And he said, no, I don't smoke. Well, did you smoke till 3 days ago? And you, oh yeah, I smoked, but I quit 3 days ago. So, oh, that becomes non-smoking, and that becomes anecdotal. So I think the challenge has been that industry is trying to get any evidence or any documentation of any of these kind of sometimes non-peer-reviewed studies, which to survive. That's the word, to survive. This is their only way to survive. Not counting that all forms of tobacco is harmful, including nicotine products like e-cigarettes, which now is showing from at least one study that there are increased chances of COVID for e-cigarette smoker. Again, it's logical to assume, oh, nobody's studying it. That's a different matter. So for WHO, we've been looking at it very systematically. We've carried out a systematic review in May, and we established that at least we confirmed that the severity of infection is higher amongst smokers. And we'll repeat this analysis very soon to see what more studies have come. And that is my overarching comment on this at this stage. Over.
Sorry, thank you. Thank you, Dr. Prasad. Dr. Egbe, may I invite you to speak now?
Thank you, Megan. I will be talking about policies and opportunities that we are seeing during the time of COVID-19 with regards to tobacco control. So we've heard a lot about COVID-19 lockdown bans, and I just want to mention that this happened in about 3 countries in around the world. So we had it in Botswana, in India, and in South Africa. I think South Africa's one was the most popular and the most controversial. So there are a lot of things that went on in the country during that period. I'll talk more about that later. But we also currently have an issue where smoking in public places was banned in Spain, started in 2 regions, and then it was extended to the whole country. And one thing about the ban is that it had its downsides and its upsides. So for the upsides, we'll look at the fact that it increased the public conversation about tobacco control, about the harmfulness of tobacco products. And of course, it created some controversies and was exploited by the industry as well. Because at some point, it was obvious that the industry was beginning to pitch the public against tobacco control and using hashtags like leave lift the ban and hashtag what next, you know. So we have an issue where there was a big opportunity for us to increase the public's awareness about the harmfulness of tobacco products, and I think it was very well used. And I believe that the help that this awareness has created for smokers and for the public generally, because at least it also reduces the likelihood of people initiating tobacco use. I believe that the gains continues, and at this point, we are looking towards how we can help smokers to continue to stay quit, because around the country, around the globe, it was found that more people have quit during the period of this pandemic than any other time in the world, in history. And so the opportunity it affords us is creating more awareness about cessation, about the importance of quitting, and about the need to stay tobacco free. For governments and tobacco control advocates, it's also created or affords us an opportunity, and that opportunity is that it made governments to understand better the role of tobacco and in NCDs, because we've been hearing a lot about tobacco-related diseases, but during the COVID-19 pandemic, the diseases that were more associated or had higher association with severe symptoms or severe cases of COVID-19 were almost all of them tobacco-related diseases. So it was easy to make the link and make policymakers and other stakeholders to understand the link between tobacco control and the burden of non-communicable diseases. And of course, when you look at infectious diseases, of course, an example is COVID-19 itself, is that we got to know that it's not just about NCDs, but that indirectly, tobacco impacts on infectious diseases outcome. So we have also the need to look at how Article 5.3, the Framework Convention on Tobacco Control, has been implemented at country levels, because at this point, the previous speakers have mentioned that many of the tobacco companies were exploiting this pandemic, and I'm sure my colleague Tom will talk more about that, but it creates that opportunity for us to revisit the implementation of Article 5.3 at country levels, because if the right measures have been put in place, it would have been harder for the tobacco industry to exploit the pandemic as it did. There's also the issue of illicit tobacco trade. In South Africa, for example, there were reports that the ban increased illicit tobacco products in the country. Of course, any product that was available during the ban was could be tagged illicit, but it created a problem that people were so worried about, including those in the tobacco control community. And I think that that creates, or that gives us a reason to rethink the participation of countries in the illicit tobacco, the protocol to eliminate illicit trade on tobacco products. And so, for example, South Africa has not acceded to that protocol, and this gives an opportunity for countries to look out for their countries' participation in this protocol in order to help safeguard the market, to help reduce illicit tobacco trade. Because if we had an international tracking and tracing system in place, it would have been more difficult for the expansion of the illicit tobacco market. There's also the issue of the support available to smokers, especially in low and middle income countries. During this time, it became very obvious that there was really not much being done by many governments in low and middle income countries to help smokers who are interested in quitting to quit. For example, there's the problem of not having many of these pharmaceutical smoking cessation aids in the medicines, essential medicines list in South Africa. And so it was difficult for smokers to have access to these cessation aids they were left to quit cold turkey, which I know, being a tobacco control specialist, it's not easy. It's because of the nicotine addiction. So I think it highlights the need for countries to do more to help smokers to quit. And because of time, I would just say, lastly, for tobacco control advocates, this period created or gave us the opportunity to increase awareness in the population, to help people understand the message we've been trying to put out there, that there is the need for people to stay away from tobacco products and to help themselves and their families to stay healthy, especially at this time of COVID-19. Thank you.
Thank you, Dr. Egbe. Dr. Hurd, it is up to you now.
Thanks, Megan. Thanks, everyone. Hello to all the participants. My name's Dr. Tom Hurd. I'm at the Tobacco Control Research Group at the University of Bath in the UK. I work with Professor Anna Gilmore there, and we are part of STOP, the Stopping Tobacco Organisations and Products Partnership. And I'd urge you to go and look at exposedtobacco.org to learn more about that partnership. We work globally, and the examples I'll give here are from low and middle income countries as well as high income countries. And I want to point out that a lot of the evidence behind my points here, I won't have time to go into in detail, but they've been collected and can be accessed through the monitoring briefs on tobaccotactics.org. So I'd urge you to look at that as well. So first, to echo Vinayak, we know that the industry has been really worried by the COVID-19 pandemic. We've seen slides from their AGM of their fears of falling consumption, falling access to new smokers to drive up their product uptake, and fear of reputational damage, which is strange to think of for an industry that's already known to kill millions every year, but COVID puts those health impacts into sharper focus than usual. And finally, as always, the industry fear regulation, as Dr. Egbe put so well. And both during COVID, but also as the governments look to cover the costs of the crisis, tax on tobacco as a major contributing factor to COVID-19 is a pretty attractive proposition. So all of this has driven the industry in big attempts to help to try to reduce these threats from their point of view. So I want to talk about 4 key strategies they've used, and this is just a taster really, so I'll try and do about a minute on each. The first is marketing. The industry has adapted the way they market to take advantage of the pandemic. And most of these efforts have focused on newer products, including heated tobacco products, such as IQOS, which is Philip Morris International's heated tobacco product. These are even more profitable than cigarettes, if that's possible, and they are quite amenable to online marketing. And during COVID, we've seen Philip Morris International use the pandemic to promote special offers and home delivery on its heated tobacco product systems in at least 18 countries around the world, sparking real concerns about whether it's possible to check the age of sale when they're selling them online. British American Tobacco were offering special prizes and even branded face masks and hand sanitizer with purchases of their products. So just some of the marketing they've used. The second key strategy is CSR, corporate social responsibility. We've seen consistently across the pandemic industry corporate social responsibility, particularly targeted at low and middle income countries and particularly targeted at health ministries and hospitals. So early in the pandemic, we saw PMI and Altria, which is a tobacco distributor, donate $30 million and $7 million respectively to various health ministries across the world. We've also seen a focus on their paying for PPE equipment, testing in Indonesia and Costa Rica, and in some cases just pure cash transfers. We saw that in Turkey early on. This is consistent with evidence that the industry uses philanthropy like this to distract from the harm they're causing, to try to facilitate their access to policymakers, and to build public trust back into the tobacco industry, despite the harm they're causing at the time. We've also seen several tobacco companies broadly publicizing their investment in companies who are trialing potential COVID-19 vaccines. And it's really important to remember these investments in biopharmaceutical companies are aimed to make the tobacco companies appear part of the solution and give them a respectable voice in the scientific debate, again, distracting from the harm they're causing. The third strategy we've seen a lot of, and Dr. Egbe touched on this, is direct policy interference, both with COVID policies and wider tobacco control policies. Basically, they're trying to shape either policy to minimize the damage to the industry at the root. We've seen them oppose efforts to label cigarettes non-essential in South Africa and elsewhere. In some countries, including Indonesia, they've ignored COVID restrictions, kept factories open and failed to protect their workers. In other countries, they've opposed and even taken legal action against government bans on tobacco sales, again, including South Africa. And they've also used it more broadly as an opportunity to shape or to interfere with tobacco control policy in particular. So they've used the distraction of COVID to push for the easing of tobacco excise taxes in Indonesia. They've pushed against flavouring bans early on in Europe and very recently in Bhutan. This is likely to continue with industry lobbying for favourable policies in recovery strategies, and I'd urge you all to look out for that. And the final strategy I'd like to touch on is about confusing the science, which Megan spoke about. So the science on smoking and COVID is complex and evolving, but we know that the industry has a historical tendency to attempt to influence scientific debate, and it's a deliberate tactic they use to divert the issue away from the causal link between smoking and harm. Now, regardless of where the evidence is, and Megan's already given an overview of that, we've seen a lot of media coverage of so-called biologically plausible mechanisms for both protective and harmful effects of smoking. But we haven't seen the caution needed around these emerging evidence fields. And the old maxim that extraordinary claims require extraordinary evidence needs to be followed here. I think Dr. Prasad said how established, as we all know, the evidence of the risk of tobacco is, and yet we saw a pattern emerging. Those with vested interests, including links to the tobacco industry, were really quick to publish and promote studies and theories suggesting smoking or nicotine is protective. We then saw widespread use of preprint platforms. Now, there's a place for preprint platforms in a pandemic, as I'm sure you'll all agree, but they do lack peer review, and they're therefore very vulnerable to influence from people who want to influence the scientific base, like the tobacco industry. We also saw widespread reporting of that early speculative research, including by media outlets with links to the tobacco industry. This has caused a lot of confusion in the public where I am, and I'm sure where you are, and has downplayed the negative impacts of smoking. So given that history and what we know so far, we're currently conducting more research to better understand how and whether the industry was involved in these things and exactly how. But I think that's an area we need to look into more. So hopefully that's given you a quick run through of some of our areas, and I'm happy to take questions. Thanks, Megan.
Thank you, Tom. There are a number of great questions, and I'm going to read them out and then suggest a speaker to answer them. I think I'll start. I apologize for the phone ringing. I think that I will start with something related to tobacco industry interference, since it builds on Tom's presentation. We have a question about, and I believe that it is from, excuse me, where is it? Shobha Shukla from Citizens News Service based in India. Her question is, has it been investigated if authors of studies which claim that smoking reduces the risk of COVID-19 had any conflict of interest with the tobacco industry? Was their study funded, even indirectly, by the industry? I will just point to one study, and then I'll let Tom speak more about it, since Stop did quite a bit of the investigative work on this. But yes, in our master brief, there's I think hopefully a helpful synopsis of this under the question regarding the French studies. A study entitled "A Nicotinic Hypothesis for COVID-19 with Preventive and Therapeutic Implications," April 21st, was published. Again, not peer reviewed, as Tom mentioned, on Kios. The primary author, Jean-Pierre Changeau, has, as Stop has pointed out, has longstanding historical links to the tobacco industry. So Tom, I don't know if you want to just speak a little bit about the study and the hysteria it caused, or about Changeau's links to the industry.
I think we've seen waves of this throughout the pandemic. Yeah, what you say, I think is true, that there are historical links to tobacco industry funding. I think with other authors and over the period, we've seen sort of subsequent studies by people who receive funding, including from PMI's Foundation for a Smoke-Free World, which also is currently has a call out for more studies on smoking and COVID. So we can expect the influence of Philip Morris International to run through those. I think what's more clear is that we've seen spokespeople promoting this information who we know definitely have links to the tobacco industry. And again, lots of information on this on tobaccotactics.org if you want the details. But I think the promotion of these studies has been as much an issue as the studies themselves. Thanks.
Great. Thanks, Tom. I will read the next question, which I believe Dr. Prasad is going to answer. This question is from Rita Widyadana, and she's from Indonesia. I'm not sure her outlet. Okay, this is the question. All of the studies conducted in the last few months regarding the relation between COVID-19 and smoking are pretty confusing for journalists to write accurate information and to avoid any misinformation and disinformation on COVID-19 and smoking. As a journalist and anti-tobacco advocate in Indonesia, where 63% of adult men are active smokers, accurate and clear information on this issue is so crucial. Questions for Megan from the Union and Dr. Vinayak from WHO. What should the media do to absorb the deluge of contradictory studies?
Thank you, Rita. I think the most crucial part is not to miss the bigger picture. The bigger picture is Indonesia needs to do more. It has regulatory policies that still lax. Its tobacco industry is exploiting it. So we need to continue to encourage the government to take tougher measures for advancing Empower package, whether it's making 100% smoke-free environment, banning all kind of advertisement sponsorships, and looking at increasing taxes and putting larger pictorial warnings. So there's scope for every single intervention in there. And it's important, and this is the time to do it. This is the best time for media to talk about raising all of these issues at the national level. This is the time, it's a lowest hanging fruit, to get the 63% smokers to quit. Tell them about the harms of tobacco. Tell them about the risks of tobacco use. Tell them that this is the best time to quit. Never a better time to quit in Indonesia than this. And if this goes out by media regularly, constantly, that to me is the most important factorial. It's not that there is contradictory information. No, there is contradictory information like 1, 2. There are positive information 10. So my direct request, if I was to use that word, Rita, is that look at the 8 or 10 studies which show that cases are more severe. More Indonesians are prone to getting into severe COVID infection if they are smokers. You already have Ncds, which is one of the highest burden for Indonesia for early deaths, premature deaths. You know, it's 50 years since WHO recognized that tobacco causes cancer in the World Health Assembly. It's more than 50 years now. And it's established that more than 12% of the cardiovascular diseases, which is the biggest killer in the world, is due to tobacco. So if those facts are known, then there is no doubt that the media should use this as an opportunity to actually market all of the lessons from other countries which are continuing to take positive measures to strengthen tobacco control. Use the opportunity to push the government of Indonesia and civil society to do more.
Thank you. Okay, not on mute. I would just add to that, as someone who has worked as a journalist myself and is actually not a PhD or a doctor and not an epidemiologist. What I would add is I understand that the data can be overwhelming because there is so much and it is coming out at such a rapid pace. But I think that at least I hope that one of the things that we do in our briefs is to, again, in the most recent brief, which is quite short and readable, and is outlines, and again, we borrowed this from an article, but outlines sort of an easy checklist as you are reviewing studies yourself, that can enumerate some of the huge study findings. So you can quickly ask yourself, is a study peer reviewed? Has it been published? I believe the WHO in its own analysis of some of the papers that are coming out is making clear that it's only reviewing peer reviewed studies. Some that are not peer reviewed might be more fraught with problems. You can look for the potential for bias. Are certain subgroups, is a study focused on certain subgroups that may have higher propensity for infection, like healthcare workers? Is the study reliant on electronic health records, hospital records during the pandemic? Again, a lot of data is missing in this. I think what journalists do best is ask questions. So as you're looking at the study, I think if your eyebrows are raised because things seem surprising or counterintuitive, there may be a good reason for that. But anyway, let's move on to the next question. Okay, this is a question for Dr. Egbe. And this is from Tibile Mibela from SABC Radio News. Dr. Egbe, do you think the ban on smoking in South Africa was justified? Did it yield tangible, positive results?
Thank you, Megan. I think that, sorry, can you hear me? Mm-hmm. Yeah, okay, I think it's justified given the available science, because we're dealing with a novel, coronavirus that people didn't have information about. Having a precautionary approach towards protecting the citizens was very key for South Africa, because South Africa is a country that has a population that is already having a lot of comorbidities that could place them at a better disadvantage. So when you compare what is happening now in South Africa to other countries, currently we have over 700,000 cases, less than 20,000 deaths. So if you compare that to other countries, one would want to say that, the government took the right decision. But that is not to say that that's the only reason our figures are low, but at least based just doing like an eyeball test, you would say they did the right thing. What I would say is that maybe the government should have done more to help smokers to quit during that period. And talking about results, you would look at studies that were conducted during the lockdown. At least the one conducted in the University of Cape Town showed that about 16% of smokers had quit. And if you extrapolate that percentage to the percentage of smokers in South Africa, you would find that that will give you about 800,000 to 1 million smokers who had quit at the early stage of the lockdown. So if you want to calculate that and the issue of the case fatalities in South Africa, one would want to think that it was successful to a good extent. And another thing I would say is that we must always remember that anything that was done to help South Africa cope better with the coronavirus pandemic was important and was good for the country. I think I would stop there for now. The second question, should I go on to respond to the second question?
Sure. Go ahead.
Okay, so there was another question about, I think I just may have missed it. Let me just check.
I can read it out if you want. Okay. Dr. Egbe, you talk about more people quitting smoking more now than ever. Can you provide some statistics on this? And what do other experts on the panel think of you've touched on this, maybe others.
Yeah, I've mentioned that. So more studies are being conducted, and I must mention that for the first time, South Africa is going to be, this is the first time I'm saying it in public, South Africa is going to implement the GATS, and so we are still monitoring the progress or the achievements or whatever gains that was made during that period. And I must mention that the issue of the illicit tobacco trade that was really prominent in the public discourse during that period has died down, because the industry was actually using that to attack the policy, just as Tom said. I think that at some point we need to understand that illicit tobacco trade or curbing illicit tobacco trade wasn't the purpose of the policy in the first place. And illicit tobacco trade in South Africa has been a problem even before COVID-19. So focusing only on that problem is not doing good service to the effort of the government to protect the citizens.
Mm-hmm. Yeah. Yep. Thank you. Tom, I've got a question for you. This is from Rita at the Jakarta Post. The number of smokers in Indonesia has increased 15%, and the number of child smokers is also increasing due to lockdown. Because the government needs money, it accepts happily donations from the tobacco industry. What's your response to that?
Thanks, Rita. Good question. Of course, countries are under huge strain from the pandemic and in a difficult position. But we have to remind ourselves that the industry, the tobacco industry is an industry that's products kill 1 in 2 long-term users. And in Indonesia, that's over 250,000 people every year. So the industry's aim with these donations is to distract from this harm, facilitate their access to the policymakers, and ultimately sell more of their deadly product. So we've got to recognize that. I'd also say we've got to recognize the huge burden of smoking on the country's health system already. I mean, globally, the economic cost of smoking is over $2 trillion. A lot of these are healthcare related expenses. And the burden on Indonesia's health system will have had a big knock-on impact on the COVID response. So I would say to back up what Dr. Prasad said earlier, I think we need to look at the bigger picture here and to contrast the huge costs smoking is already having with the comparatively small donations the industry is making to prop up their business model, which involves the sale of that deadly product in your country. So I would consider all of those things. Thanks.
Thank you. I think we've got time for one final question. This is from Shobha Shukla at the Citizens News Service. This is Dr. Prasad, a question for you. In many countries, alcohol and tobacco shops were among the first to be open when lockdown was partially lifted. Why did governments do this despite scientific evidence on the hazards of smoking, particularly lung health and COVID's attack on the respiratory system?
So thank you for that question. I think the most critical thing to remember is that more countries have imposed restrictions and bans. 17 countries imposed temporary ban on water pipe. India, for example, has imposed stricter regulation on spitting and chewing. Many states in India did open up, for example, the alcohol shops earlier and even tobacco shops later for economic reasons to collect their taxes. But I think overall the response has been, they need money for their taxes and they had to open it up after some time. And also the South African government had a similar challenge that after a few months, it was only a question of, as Egbe pointed out, is the illicit trade issue starting to overwhelm, but also the tax collection was going down. The governments need to run. So unless until they find other sources of investment, they will have to look at alcohol and tobacco taxes. But the point we have been arguing is increase the taxes. It's addictive, increase the taxes. You want revenue, get it. But don't lower taxes, increase it and make it difficult to smoke. So there are benefits to getting less number of smokers. 13% to 16% decline in South Africa is a big win if we can sustain it, because that's going to save almost 25 million lives. That's big. Over.
Yeah, thank you. I think that we are almost out of time. If there are any more questions from media, from the journalists, please type them in now. Otherwise, what I do want to mention, I meant to say this earlier, is that if anyone has questions or would like to speak to any of the panelists one-on-one, we can certainly arrange that. Please just be in touch with Michael Kessler, who can certainly facilitate a more in-depth conversation with any of us. I know all 4 of us would be happy to speak. I'm just keeping an eye on the Q&A. If there's anything else, or I don't know if any of the panelists have anything final they would like to add. I don't see any hands raised. Again, I want to close out by saying thank you to everyone for joining us. I know that for our colleagues in Asia, particularly, it's quite late at night. You need to get some rest. And thank you for being with us. We really appreciate it and think this was a productive, fruitful conversation. Take care, everybody.
Thank you.
Thank you.